Hi, and welcome to another episode of Under the White Coat. My name is Dr. Saeed Darvish, cardiologist in Brampton, Ontario, and co-founder of KeyOps. This is our weekly series where we sit down with key opinion leaders in medicine today and explore some of the thought-provoking and groundbreaking topics that are affecting doctors today. We're hoping you learn something new and also get to know a little bit about the personal side of these leading doctors. Today, I'm joined by Dr. Darryl Leong, cardiologist in Hamilton Health Sciences and an investigator at the Population Health Research Institute. He's known amongst our cardiology circles as an expert in cardio-oncology and is the director of the cardio-oncology program at McMaster University. Without further ado, I'd like to introduce our guest, Dr. Darryl Leong.
Thanks very much, Saeed, for the invitation.
Darryl, I hope I haven't given away too much in that little intro. Maybe you can tell our audience a little bit about yourself.
Sure. So I originally hail from Australia, from the land down under. I did my cardiology training there, my PhD and master's degrees there. And it was actually on a postdoc fellowship that I came to McMaster to work with Salim Yusuf. And after spending a couple of years with him, they offered me a position on faculty. The piece of advice that Salim gave me that I've really taken to heart is to try to do clinically and research clinically what you feel is the most important thing. And what struck me, has always struck me in my clinical years of service and training, is that the patients we see are complex nowadays. They're not single disease patients. It's rare to get someone with just a myocardial infarction and that's their only morbidity. Typically, people have multimorbidity, and so that's really where we focused our clinical practice and clinical research. And cardio-oncology is really just one major offshoot of multimorbidity, I think. The reason we're doing it is that people are surviving longer and longer with cancer, with plenty of advances every week, it seems, in the New England Journal and the Lancet in cancer therapies. And so we are frequently faced as cardiologists with management dilemmas in these patients. And so there is a real need for these sorts of cardio-oncology services that are springing up all over the country and worldwide. And so when I was asked to establish this program at McMaster, it was actually a real pleasure to do so. It wasn't really a specialty back when I was training in residency, but it's certainly quite well established now, I think it's fair to say.
Absolutely, we're seeing more and more trainees come out and more clinicians practicing it. For the people who may not be familiar, what is cardio-oncology and what are the major areas of clinical focus in that specialty?
We really do three things in cardio-oncology. One is addressing cardiotoxicities and cardiotoxic side effects from various cancer therapies. And there are quite a number of them and they're fairly nuanced. So without some sort of content knowledge about cancers and their treatment, these are difficult things to deal with. The second thing we deal with is the dilemma of how aggressive or invasive to be in a patient with an established or advanced malignancy, because they don't play by the typical rule book. The guidelines were not written with this patient population in mind, and so there are particular considerations that need to be brought to bear on their management. And the last emphasis of ours is really survivorship. How do we ensure that people who have survived cancer have the best possible quality and longevity of life available to them? And so we do this mostly on an outpatient basis. Most of our work is ambulatory. We also provide coverage for patients at the Jurinsky Hospital with cardio-oncologic problems.
That sounds amazing and obviously quite complex. For the general cardiologist who, having been at McMaster, I understand how the Jurinsky Clinic worked and what type of patients would be referred there. When you get out there in the community, it's often not the same. They don't have the same level of resources, or the general cardiologist may not be as familiar with some of the nuances as you kind of mentioned. Some of them can't even pronounce the names of these chemotherapies and the immunotherapies, and they're rapidly evolving. What are some tips or pearls that you would say for the general cardiologist? What are the key things that they need to know in order to help manage these complex patients?
Look, I think increasingly at both academic and community-based centers, these sorts of departments, if you want, for want of a better term, are growing. For instance, we work with Kiba Yared at Scarborough, who is made a real sort of niche for himself there, seeing cardio-oncology patients. And the same can be said in Oakville and a number of other community centers that we sort of collaborate with and have spoken with. I think the first step is probably getting to know your oncologists and hematologists. So, and the second step is probably having somebody or a couple of people at least who notionally are more invested in this sort of area, and empowering them to sort of meet with the hematologist, oncologist, find out what their needs are or the needs of their patients are, and figure out a referral system that works. Because when we first did this at McMaster, some of the feedback we got was, number one, I don't know who to refer these patients to. We send in a general cardiology referral form, and we don't know if the cardiologist seeing this patient knows, as you say, about what these cancer drugs actually are. Second of all, they are put off, I think it's fair enough to say, when they get sent back a letter from the cardiologist to say, yes, everything's fine, no more follow-up is necessary. Because again, survivorship is really important for a lot of these cancer patients, and obviously they're oncologists. And so what they want to see is a continuity of care. And that's difficult to provide in many general cardiology settings. But if you can design your practice appropriately, I think it makes for a very rewarding practice for your patients and for yourself and your colleagues in cancer and hematology.
That's excellent advice, I think, for the community, especially, and that's what we're trying to hopefully set up in our own community clinic. As you can, it's always challenging to make sure the cardiologists are appropriately trained. You did extra training, obviously, in cardiovascular imaging, and you're big in research. What are some of your current research interests, and what are the projects that are happening in cardio-oncology?
So in cardio-oncology specifically, we have a big program for prostate cancer patients. We've recruited about 2,700 Canadian men with prostate cancer, and are following them to understand why many of them seem to develop cardiovascular disease, and the extent to which hormonal therapy for prostate cancer contributes to it. But we've actually done something kind of neat with it. We've embedded a randomized trial. So half of these men actually get referred to a cardiology service or an internist, and they have their risk factors sort of treated very systematically. And it's really a proof of concept that actually having a cardiologist as part of the care team for men with prostate cancer may be beneficial. So that's what we're trying to evaluate. In the field of breast cancer, that's obviously another large group of referrals that we get. One of the questions we're often asked is, should we continue with Herceptin, which is a life-prolonging breast cancer therapy, in patients where they've developed some sort of cardiotoxicity from it? And so we're currently doing some research in that. We have some protocols to try to address this issue, and we have some evidence base, at least, that we can use to guide patients and their physicians. But really, the list goes on, Saeed. I mean, I've just been talking to a group at Harvard about checkpoint inhibitor toxicity in myocarditis, which can be very lethal. And it's only something that's just being recognized in the past few years. And so you can pretty much name easily a dozen different cancer therapies that have quite diverse adverse effects. And to your point that it's hard for a general cardiologist who's had limited experience with this kind of thing to be on top of it all. And that's where I think having an initiative like yours, actually, where you're able to network with people and and to contact folks with a little bit more experience might be really useful, because we can certainly happy to provide guidance or advice to folks out there who are less familiar with this.
No, that's amazing. And even myself, I always come back to you guys. I remember asking you guys lots of questions. We get that question quite a lot. Even I do a lot of the cardio-oncology at my hospital, but that question about Herceptin comes up constantly. The checkpoint inhibitors have emerged as a new thing. We've seen cases of myocarditis. So it's been great to be able to to send back cases to you guys. And it's a really good partnership that we've been able to develop, and hoping to grow it. Now, I guess the elephant in the room, it's on top of everybody's mind, the big thing that has affected medicine, the big topic, COVID. How has COVID-19 impacted your clinical practice and your ability to do research, actually?
Yeah, so in terms of clinical practice, all the elective work actually dried up, as it did for everybody. And so that, principally affected our echocardiography service. It meant that inpatient services were very quiet. And in terms of the cardio-oncology outpatient work, which is the bulk of my work, That's probably one area where I would say it was unaffected, because the cancer center actually continued with business as usual. They gave patients, a lot of them, the alternative of deferring their cancer therapies, and the patients, they voted with their feet, so to speak, and said that they wanted to continue therapies, and so we kept getting the referrals. Fortunately, we've been able to deal with a lot of that by video links and by telephone consultations, and we've only had to actually physically see a relatively small number in person, and we've been able to arrange that, and that's how we've coped in cardio-oncology for now. With regards to the research, we're in a kind of a fortunate position, just purely by happenstance, that our trials were not in a phase where they were actively recruiting heavily. It's mostly affected clinical research in trials that were right in the middle of recruitment, because that obviously got totally interrupted. So we've been kind of fortunate in that regard. Still, it affects everyone. Our staff have had to work from home, as you might expect, but it's a price that we all have to pay at the moment.
And that's really great to hear that the research hasn't been impacted. I know you may not, you're a very humble guy, you may not mention it, but it recently was announced that you're doing a new research trial with COVID in the PURE sub-study. Can you tell maybe our listeners what that particular trial is about and what you're hoping to accomplish?
Yeah, we were very grateful that CIHR and the IDRC funded us to take a subset of the PURE cohort. PURE is a big cohort study, including 200,000 people from about 26 countries worldwide. And it's led by Salim Yusuf, and it's coordinated by PHRI. We proposed studying about 40,000 of these individuals and testing whether or not they've had exposure to COVID by serology. So we've partnered with Matthew Miller's lab at McMaster. We've got serologic assays lined up, and we'll be testing basically a random set of 40,000 adults from around the world. What we aim to do is identify the hundreds or thousands who've actually had COVID, whether they know about it or not, and identify what characteristics predispose them to getting infection and what predispose them, if they did, to getting severe infections. So we've got a range of characteristics, the usual sort of demographics and comorbidities and so forth. But we also have measures like their diet, their physical activity levels, alcohol and smoking history. We have their physical strength measurements, all sorts of things like that. And so we hope to be able to gain some insights as to why some people seem to be susceptible to infection and others do not. That aside, we actually are looking to see whether they get lung damage because, as you know, that's one of the most feared complications of COVID. But we wonder whether people with even mild infections actually do have some residual lung deficits. And so we're doing lung functions on hopefully all of these people to see if they've got abnormal spirometry as a consequence of the infection.
And is this going to be a retrospective review, or what? How is the actual study design?
So patients had their baseline characteristics already collected, and that was part of the efficiency of the study. So now all we need to do is identify who's had COVID by the serologic test, ask them a few simple questions about whether they had any symptoms related to the infection or not, and measure their lung function. And so we can generate results in a large cohort really quickly. We're hoping to wrap this up by the middle of next year. And so hopefully we'll have information that'll be valuable to communities and societies that are still trying to contain the infection.
That sounds amazing. I think the impact of such a trial result is going to be huge. Is that the ability that you guys, the fact that you guys have the capacity to process and handle all that data and have access to that data is going to be quite groundbreaking. I definitely look forward to the results. I mean, I guess the one positive in COVID has, I mean, the way you think about it, with the lockdown and the quarantines that everybody has to go through, a lot of people have picked up new skills or hobbies or done things that they may not have ever been able to do. I know, Darryl, if you may not know this, but I've really got into exercising, and I'm proud to say I can finally bench press 25 pounds. No, I'm kidding. Is there any particular skills or hobbies that you picked up during this lockdown, or things that you got to do that you may not have been able to do otherwise?
I play tennis, Saeed, and the one boon about tennis is that it is a socially distanced sport, kind of by necessity. Yeah. And so once the tennis courts opened again, we were able to get out. And my best thing is I've switched rackets from the old Roger Federer racket that weighed a ton to something a little lighter and easier on my old shoulders. So that's been fun to get out in the beautiful weather and play some tennis.
That's amazing. Well, Darryl, I think our listeners are definitely going to appreciate the fact that you were able to speak with them today, the insights that you provided. We're definitely going to be on the lookout for the results of your study. I think it's going to be quite groundbreaking. And I just want to thank you again on behalf of all of our listeners for joining us today.
No, thanks very much, Saeed, for taking the time to speak with me.